Dr. Isaac.
Good evening. I am Dr. Lisa Isaac, President of Gateway Medical Society, and on behalf of Gateway, I am pleased to warmly welcome you to our 2021 Virtual Provider Symposium. Gateway Medical Society is a component of the National Medical Association and was established in Pittsburgh in 1963 with a principal mission to eradicate disparities in healthcare. Among the numerous ways we work to bridge the gap is through providing education and facilitating communication and collaboration with healthcare providers. Of course, as has been the case throughout this pandemic, we have had once again to adjust and convert our face-to-face symposium format into a virtual one. The theme of our symposium this year is the risk of HIV in African American males, physician updates. We have an excellent moderator and dynamic keynote speaker. Timely and practical information will be presented with opportunities to interact. We are truly glad that you have taken the time to join us today, and we are confident that your time will be well spent. This activity is presented in partnership with the Hines Endowments, UPMC, Highmark, and Gateway Health. We acknowledge our sponsors, and as always, we are grateful for their support. And now, allow me to take a few minutes to introduce our moderator, Dr. Anita Edwards. Dr. Edwards is a medical director at Gateway Health. She received her Bachelor of Science from the University of Pittsburgh and MD from Howard University School of Medicine. She later received a Master's in Business in the Physician Executive Program of the University of Tennessee, and she also has received the title of Fellow of the American College of Physicians. Dr. Edwards was employed as an internist for 28 years, mostly working with Century 3 Medical Associates. In 2016, she became employed by Gateway Health, where she has started and chairs the Health Equity Committee, along with several other projects that involve issues of disparity. Dr. Edwards has been actively involved in Gateway Medical Society since 2004, serving as treasurer, secretary, vice president, and president. It was her signature to help change the course of the organization to one of service to the community and its network of physicians. At the end of her presidency, she continued to play an active role in the organization. In 2008, she became the chairperson of the program committee, which houses 3 of the 4 signature programs of the society, including this provider symposium. She has been a successful chairperson of the community symposium and was the visionary for the mentorship program for African American males, Journey to Medicine. This successful program helps to breach the pipeline of people of color in the medical field in the city of Pittsburgh. Gateway Medical Society honored her as Physician of the Year in 2014. Dr. Edwards has been active with the National Medical Association, the parent organization of Gateway Medical Society, and is currently treasurer to Region 2. She's a member of multiple other medical societies and organizations and is also an officer and active member of Alpha Kappa Alpha Sorority Incorporated, Alpha Alpha Omega Chapter. Dr. Edwards is one of great faith. She is currently a member of First Emmanuel Tabernacle Church, where Bishop Wade Jones presides. Although she has been there for only a brief time, she has been active in many areas of worship, and during this ministry, under this ministry, she became an ordained elder. She is grateful to the Lord for giving her her biological daughter, Ashley Edwards, for Ashley keeps her motivated in the path of service. She is blessed to still have her mother, Naomi Edwards, who has always shown her unconditional love and supported her when others did not think her dreams were possible. So without further ado, I proudly present to you our moderator for this evening's program, Dr. Anita Edwards. Dr. Edwards.
Good evening. We're so happy you have joined us this evening for this program, HIV in African American males. We feel that this is such an important topic for our community. We realize that HIV is on the rise and that we need to be able to talk about it, understand it, so that we can care for our patients. We are very honored to have Dr. Marvin McGowan as our speaker. Before I do his introduction, I would like to remind everyone, and we will also put it in the chat, that if you want CME for this particular event, please email administration@gatewaymedicalsociety.org. That is administration@gatewaymedicalsociety.org. Please include your name, and then we will be able to provide you with your CME credit for this event. So let us go on about Dr. McGowan. I have to say he is a friend of mine, and I am very proud to be able to introduce him. I have found him to be someone who's very compassionate and loves his patients, and especially the community of the LGBTQIA. Dr. McGowan is a physician with Central Outreach Wellness Center in Pittsburgh, Pennsylvania, a community medical clinic focused on the care for LGBTQIA plus patients, people of color, and those in recovery. He earned his doctorate in osteopathic medicine from the Lake Erie College of Osteopathic Medicine in 2001, and board certification in family medicine in 2004. He received his board certification in functional medicine from the Institute Functional Medicine in 2021. He is a member of COSIN Immunology. Prior to becoming a doctor, he was a senior process engineer with Mobile Chemical Company, specializing in system control and process design. He holds Bachelor's of Science degree in chemical engineering and biochemistry from Case Western Reserve University in his native Cleveland. Dr. McGowan currently serves on the board of True Tea Pittsburgh, a local Black LGBTQ entertainment and social advocacy organization. In 2018, he was named Physician of the Year from the Pittsburgh Gateway Medical Society. He also was the treasurer for the society. He resides in the Pittsburgh neighborhood of Swiss Elm Park with his husband of 25 years, Kirk Colborn, a retired nuclear physicist and an engineer. His spare time, he enjoys playing trumpet, classical guitar, and piano, and he's an avid knitter and crocheter. I am not sure when he has that spare time, but we do know that he does a lot. We are proud of him, and we are very thankful for him to be our speaker for tonight. So Dr. McGowan, I give it to you.
Thank you, Dr. Edwards, for that wonderful introduction. I also like to thank Gateway Medical Society for the invitation for me to speak tonight. Today, we are going to be focused on primarily actually PrEP. Again, the risk in HIV in African-American males is a real thing. This is something that is near and dear to my heart, given that I've been HIV positive for nearly 35 years. And so we're going to get going here. So the objectives of tonight's discussion are realize the risk of HIV in African-American males, to understand what is PrEP, what medications are used for PrEP, and who is to be offered and prescribed PrEP, to understand how PrEP is initiated and prescribed, to be aware of the potential side effects of PrEP, to know how long it takes for PrEP to become effective, to know PrEP failures and reasons for discontinuing PrEP, and to recognize the barriers for starting and providing PrEP. HIV was discovered in 1983, and we know since then HIV has affected people of color disproportionately, and more so African-American males, and especially those men who have sex with men. Based upon the US Department of Health and Human Services data from 2019 and the CDC data from 2018, African-American men who have sex with men have a risk of HIV as high as 1 out of 2. African-American men are 8 times more likely to contract HIV compared to white men. African-American men are 6 times as much likely to succumb to HIV and AIDS. African-American men who have sex with men are 79% of the cases in African Americans, and also 6% of the new cases in 2018. This is preventable. So what is PrEP? PrEP stands for pre-exposure prophylaxis. This is a medication we're going to get in advance to patients to prevent them from contracting HIV. The goal of PrEP PrEP should not be confused with PEP, which is pre-exposure prophylaxis. Truvada was approved for HIV in 2004 and first approved for PrEP use in 2012. Descovy, the second medication, which is now being used for PrEP, was approved for use in combination with other HIV medications in 2016 and approved for PrEP in 2019. Both medications contain HIV analog nucleoside reverse transcriptase inhibitors, which block the enzymes which allow HIV to replicate. Truvada is composed of two medications, emtricitabine and tenofovir disoproxil fumarate, which is also now available in a generic form. Descovy is also composed of two medications, emtricitabine and tenofovir alafenamide. The doses that we currently use of these two medications for Truvada is 300 milligrams of the emtricitabine and 300 milligrams of what we call TDF. Descovy also contains 200 milligrams of emtricitabine, and TAF is 20 milligrams. These are the doses which are used for adults. There are doses that are approved for adolescents or pediatrics based upon weight. There have been many studies regarding the use of PrEP in a variety of populations. An early article, which was published in the New England Journal of Medicine in 2010, titled Pre-Exposure Chemoprophylaxis for HIV Prevention in Men Who Have Sex with Men, showed PrEP had an efficacy of approximately 97%. Later studies concluded PrEP has an efficacy of 99% when used properly. So what are the indications for using PrEP? Truvada is indicated for children starting at age 12 years old and adults weighing at least 77 pounds who are at risk of contracting HIV via sexual intercourse, which includes individuals who are at risk for HIV from receptive vaginal sex. Descovy is indicated for children and adults weighing at least 77 pounds who are at risk of contracting HIV via sexual encounters, but excludes individuals who are at risk for receptive vaginal sex. This is because the studies with Descovy were not performed in women. They were performed in women over in Africa and in Europe, but not in the United States, and therefore it has not been approved essentially for women in the United States. So who ought to be offered PrEP? PrEP ought to be offered to all patients who are at risk of contracting HIV and all adolescent men of color and adult men of color at every office visit. The people who ought to be offered PrEP does include, again, men who have sex with men, regardless of HIV status, pregnant women, sex workers, trans women, non-binary individuals who have sex with men, and intravenous drug users who share needles. The CDC has also started to draft a new set of guidelines regarding PrEP in May of 2021. This, we have actually already implemented at Central Outreach those guidelines, believe it or not, actually 5 years ago. And as far as I'm concerned, this is a perfect example of how medications have not been approved for use based upon the science, culture, and with cultural bias, and also sexism. Today, we still have clinicians who do not routinely test their patients for STI and HIV, despite recommendations from the United States Preventative Services Task Force. They do not ask patients about STI and HIV history, despite risk factors for acquiring HIV, and do not have candid discussions about patients' sexual preferences and practices. Earlier this summer, there was a health fair that was held by a local FQHC targeting African Americans, and it was very interesting when you look at what was being offered. There was nothing on drug and alcohol. There was nothing on mental health. There was nothing on hepatitis C, and there was nothing being presented or provided regarding HIV. So how is PrEP prescribed? Currently, there are 3 treatment modalities. There's daily PrEP. There's something called PrEP 211. And then there's another program called PrEP to Me. Initiating daily PrEP is for individuals who, again, may be at risk for HIV. These individuals are first given a rapid HIV test. They are also tested for chlamydia, syphilis, gonorrhea, HIV, hepatitis A, B, and C for baseline kidney function and liver function, and a urinalysis which checks for the presence of protein and glucose, indicating possible renal impairment. Again, at these visits, you must ask about sexual preferences and practices, condom use, and drug and alcohol use. Both medications, Descovy and Truvada, are contraindicated in individuals with positive HIV rapid test or known to have HIV. In patients with creatinine clearances below 30 millimeters per minute or stage 4 chronic disease, patients with end-stage renal disease with GFRs less than 15 mLs per minute and who are on dialysis. Again, in the United States, with respect to Descovy, it is not approved for those patients who are engaged in receptive vaginal sex. A few other things. Caution must be taken when prescribing PrEP to patients with active hepatitis B because they can experience a liver or hepatitis flare-up in those cases. And if that happens, the medication ought to be discontinued. And the last thing is women who plan to breastfeed, again, emtricitabine can be passed in breast milk. So if the rapid HIV test is negative, you can proceed with prescribing PrEP. Daily PrEP is taken 1 pill daily with or without food. The time of day is not that important as long as it's taken once daily. Okay, at our clinic, Central Outreach Wellness Center, we actually do a loading dose with our patients in which they take 2 pills right there in the office at their appointment, and then they take 1 pill daily from that point on. Now, by giving the patient a loading dose, this increases that concentration of the medication in the system to the point whereby they actually receive protection within 2 hours. And so after 2 hours, they are allowed and they can participate in unprotected intercourse and without any risk of contracting HIV. If a patient requires dialysis, and again, this is not a patient who's routinely receiving dialysis for end-stage renal disease, that patient can take PrEP after dialysis that day. All right, PrEP 211. PrEP 211 is currently not approved by the FDA for use in the United States. It is being used over in Europe. And this is, PrEP 211 is only for patients who are engaged in receptive anal intercourse. Okay, and so how does this work? Again, the patients are going to go through the usual screening and testing process that is used for daily PrEP, again, which includes all the tests for the STIs, HIV, hepatitis, and liver and kidney function. Okay, and again, you're going to inquire about use of alcohol and drugs at this time. All right, and what they're going to do is 2 hours before they engage in sex, they're going to take 2 tablets of either Truvada or Descovy. And then after they have sex for the next 2 days, they take PrEP and Descovy, just 1 tablet daily, and then they're done until they decide to engage in sexual intercourse again. All patients in both of these cases are tested every 3 months for HIV, STIs, and liver and kidney functions are also checked. So also, again, so what happens if we are, a patient comes in for PrEP and the HIV test, rapid test is positive? Again, depending on the last time they had intercourse, if it's actually within 72 hours, we're going to initiate PEP, which is prophylaxis exposure, in which we would start them typically on a combination of Descovy or Truvada with Tivicay. And if it turns out they've had sex beyond 72 hours, then we're going to initiate HIV treatment, and then also order additional labs to work them up for HIV, which includes resistance testing. All right, so the third way of prescribing HIV or receiving PrEP is through the PrEP to Me program. The PrEP to Me program was launched earlier this year by Central Outreach Wellness Center, and it's a federally funded program by the Pennsylvania Department of Health. It is available for individuals who live in Ohio and Pennsylvania, and individuals can register online, and test kits for STIs, HIV, kidney, and liver function are mailed to the individual's home. They set up what we call a teleprep visit with one of our care coordinators. And once they receive the kit and provide all the samples that are needed, they put those samples in an envelope, which is returned directly to one of our labs and tested. And then the individual will receive PrEP in the mail in 3 to 5 days in discreet packaging. We accept all insurances for PrEP, and then for those patients who do not have insurance, we still are able to provide that for free. And again, for other patients who are being prescribed PrEP, if they do not have insurance, there's also a medication assistance program through Gilead. The most common side effects of PrEP are nausea and diarrhea. These symptoms usually resolve in a few days. Other side effects from PrEP can be immune system reconstitution syndrome. So what this entails is, again, when you take an antiviral medication, you may not only suppress, viruses. Well, let me phrase it a different way. You wind up suppressing other viruses that are active in the body, and the system, your body may have a response to that new suppression, okay? So sometimes these patients think they're having an allergic reaction to the medication, or they're becoming sick from the medication, and actually it's just an immune system response indicating that actually the system is actually more robust because of immune suppression. Another thing that can happen, a side effect, is worsening kidney function or liver inflammation. Again, the GFR and the renal function is being tracked over time, and if it drops below a certain threshold, the medication will be discontinued. Again, sometimes the medication can alter metabolism in the muscles and cause lactic acidosis. Patient will again complain about muscle pain and aches. Again, this may be another condition in which for PrEP will need to be discontinued. And the last is severe liver problems. Again, patients with hepatitis B can have flare-ups. Patients with fatty liver disease can also have increased inflammation due to PrEP. So how long does it take for PrEP to become effective? For those who bottom, these are people who are anal receptive. PrEP is effective in 7 days. Okay, for those who engage in receptive vaginal sex and intravenous drugs, PrEP reaches its maximum efficacy in 21 days. There's no data for those who engage in penetrative sex, whether it's vaginal or anal. With PrEP 211 and the appropriate patient, the 2-tablet loading dose again reaches effectiveness in 2 hours. Excuse me. So what happens if a dose of PrEP is missed? First of all, understand that Truvada can remain effective for 10 days after the last dose. Descovy can remain effective for 16 days after the last dose. Often we'll hear patients say that they miss a dose or two. here and there, that's not of much consequence. But the problem is we have patients who actually sporadically take Truvada and Descovy. At times, they will go 2 days here, take it a day, another 3 days off, take it for a couple of days. Those patients are very high risk of contracting HIV, despite the somewhat lengthy half-life overall and efficacy of the medications. One thing that can be done for those patients is, again, they can be provided pill bottles, which will alert them to take their medications at a specific time. And again, a lot of us have phones and watches, which can be set for, set with alerts to let the patient know it's time to take your medication. So reasons for treatment failures and discontinuing PrEP. Again, the individual may no longer be engaged in sexual activity. That individual may lose insurance and doesn't realize that there are programs which may help with the cost. Individual may simply fall out of care for numerous reasons. They may not want to longer come to the clinic. They may be afraid of the stigma associated with taking PrEP. They may lack transportation. They may lose housing, drug abuse, mental health. All those things can contribute to failure of PrEP. Sometimes the individual may enter a monogamous relationship and no longer need to require PrEP with another individual who is HIV negative. And then the last thing, again, some patients simply cannot tolerate the side effects of PrEP. So individuals may stop taking PrEP 2 days after their last sexual encounter. And again, keep in mind, patients with hepatitis B must have their liver enzymes and Hep B DNA viral loads monitored for a few months to make sure that, again, that liver is not flaring up. So what are some of the barriers to PrEP? Again, racism, bias, bigotry can enter the picture, in which providers or clinicians are not providing PrEP based upon their own beliefs. Okay, there's still a lot of mistrust within the medical community. And it's very interesting. There was a lecture presented through the Institute of Functional Medicine earlier this year about cultural bias. And even within the Black community, it was very fascinating to find out that even now, today, 60% of Black folks don't trust Black doctors. How about that? Again, there's a fear of possible medication side effects. There's a stigma which is attached to PrEP. Again, there's a presumption that individuals are either precocious or deviant in their behavior, or there's a presumption that they are HIV positive, because some people will look at a medication list and don't realize if they see Descovy or Truvada by itself without Tivicay, that is actually PrEP, that is not actually treatment for HIV. There's also a belief sometimes that there's inadequate prescription coverage. Again, there's lots of ways to obtain those medications for free. Another important aspect of barriers to to PrEP, are parents not talking to their children about sex and its associated risk. This is a big problem because, again, we have seen a rise in the number of HIV cases in young Black men in particular. Even though the prevalence of HIV over the years has decreased, it is still pretty predominant in that age group. And so again, having those talks about sex and about STI prevention and HIV prevention earlier in those pre-pubescent or pubescent years is super, super important. And then there's also an attitude amongst adolescents and adults. There are attitudes of indifference, and there's attitudes of invincibility, as though, like, okay, I can go out and have sex and do anything I want. I'm not gonna contract HIV. Okay, so the conclusion. So what do I think about PrEP? I think that all sexually active African Americans are to be offered screening for STI and HIV at every appointment. I believe PrEP is to be offered to all sexually active African-American men and boys. PrEP is readily available and covered by all insurance plans. Medical assistance programs exist for those with inadequate coverage. And for those who are uncomfortable visiting a clinic, PrEP to Me is offered by Central Outreach Wellness Center for those living in Pennsylvania and Ohio. And there are actually similar programs throughout the country provided by clinics in different cities and states. Okay. Clinicians must address their bias, which hinder their ability to provide comprehensive and culturally competent care. So those who are uncomfortable dealing with men who have sex and transgender and sex workers, intravenous drug users, you really need to recognize these populations. And if you're not willing to provide PrEP for this population, at least be knowledgeable of where you can refer these patients for treatment. A couple other things, again, patient follow-up and compliance is very important when PrEP is prescribed. This is crucial to prevent the acquisition and spread of HIV. We need to have more open discussions about sex and PrEP, and this needs to be initiated by clinicians and parents. So again, we need to get parents on board with this. Okay, we also need to promote healthier attitudes regarding sex and eliminate the stigma associated with sexual preferences and practices. And lastly, we must meet the patients where they are. So again, when we come in, we need to start these discussions, initiate these discussions with a tone to make patients comfortable about having these discussions. Okay. Lastly, again, there's lots of resources and guidelines that are available. Again, you can look at the CDC website on HIV. I think the CDC provides a synopsis and information about HIV and PrEP that's very accessible to the public. It's very easy to read and understand. There's also the United States Preventative Services Task Force, even though I think they're lagging behind in terms of their culture of competency and recommendations for the use of PrEP. You can always contact myself or other clinicians at Central Outreach Wellness Center. You can contact the Allegheny County Health Department. There's the Positive Health Clinic. There's Allies for Health. There's Planned Parenthood. And also there's a website called The Body. This has been a good resource for HIV and AIDS. It is run by doctors, and anyone can go on there and ask questions they have about HIV and PrEP, and the doctors will get back to you in a timely visit. Okay, with that being said, if there's any questions about PrEP, I'm willing to answer those questions now.
All right, thank you, Dr. McGowan. Tamara, you can bring me back on screen. Dr. McGowan and I can have a fireside chat. So Dr. McGowan, we thank you for this conversation, and you have prompted me a lot of questions. I think that you kind of answered my one question, but just to maybe start out there, and we may want to end there also. You talked about programs and how people sign up. I think that you were definitely talking about the
PrEP to Me?
Yes, the PrEP to Me program. So how would someone go about finding that program?
Thank you for asking that question. Yes, you can actually just type in PrEP, www.prep2me, PrEP, the number 2 ME, and that website will come up, and there's a ton of information on there about how to get PrEP directly to your home. And so again, what happens with PrEP to Me is you'll go in and you'll register. We have a clinician who will get in contact with you for a teleprep visit. There will be a kit that will be sent to you for STI HIV testing and urinalysis. And there's an envelope that's included with that kit, so they can put all of those samples back in the envelope and just put it directly in the mail. And it is at no cost. And again, it's available for anyone who's interested in PrEP in the state of Ohio and Pennsylvania.
So what about my privacy, me going over the computer, internet? Do I need to worry about my privacy as far as trying to enter the program through the computer?
No, it is a secure website, and it is HIPAA compliant.
Okay. So then as a clinician, what would I do if I was trying to get I know you talked about some are not very comfortable about doing this, but how can they help their members get to these kind of programs for their patients?
Again, I think part of our medical intake, history and physical, does need to include sex. It's kind of ironic because I was at a conference back in August, and there's always something about legal medical ethics stuff, and the lawyers are saying you should not talk to patients about sex. I'm like, are you nuts? I talk to my patients every day about sex. No, we have to have those conversations. We have to be comfortable with asking those questions. What are you doing? And I don't necessarily record that type of information on the patient's chart, okay, unless the patient is being in danger somehow. But again, we have, and I let them know that also, okay, because I got to get them to open up. I need to know exactly what they're doing. I let them know that I need to know because it's for a medical safety issue, and it's going to help me also determine the best way to care for them and keep them safe. I often tell my patients, my job is not to judge you as to what you do, but my job is to try to keep you safe and make you aware of how we can keep you safe. So I think, again, from a clinician standpoint, you just have to let it rip. Okay, you just have to be very direct with the questions and know that you're not there to be, that you're not trying to pry. This is a serious medical issue. I think you will find that patients are more often more comforted that you have brought that topic up because they're typically afraid to bring it up. Okay, especially within my trans patients in particular. They says, oh my God, I'm so glad you brought it up because, I was afraid to discuss it, et cetera. They're embarrassed or something that goes on because, again, with the trans females in particular, again, we're giving them estradiol, which is going to counter testosterone, which may decrease their libido and also lead to erectile dysfunction. Okay, so there's a lot of things that have to be learned. Just very quickly here, to give you an example, with our trans female patients, again, there's a spectrum in terms of sexual libido and desire. There's at one end of the spectrum, there are patients who want no erectile, they don't want erections, and they want no sexual desire. And then there's another group who may just want the libido intact, and there's some who still want to have erections and libidos. And you have to find a healthy balance with the hormones or levels for those patients, okay? And you have to have those discussions, and you have to try a lot of different things and find out what works for that patient. So that's an example of how, there can be some very uncomfortable discussions that the clinician needs to have with patients.
All right. And I think that leads into one of the questions we just heard. I do realize that clinicians who've been out here for a while, this is really all new to them. And even though you said AIDS has been around since 1983, I do remember when I was in med school, show where I was, back in 1980 when it first hit, and I was at Howard University. I just remember when AIDS came out and how frightening it was to us. I was telling someone, it reminded me very much of what we're going through with the pandemic. We used to dress from head to toe with looking like we had little space suits on because we just didn't understand it. But do you see that the schools are now preparing the students more? Are they teaching them about PrEP? Are they teaching them different concepts of how to handle this information and how to gather information so they can treat their patients?
I do not know that because I don't have a large pediatric population. I know that we do a lot of outreach.
No, I said the medical students. I was talking about medical students. Do you think they are receiving this information in school?
Ooh, I don't remember. I don't know. I mean, I don't remember receiving a lot in terms of HIV care when I was in medical school. I know I was involved in getting HIV introduced to the program at UPMC McKeesport when I was a resident there. I actually helped them have their first HIV conference. that was one of my projects along with Nina Tomeno. And then after that, we broke out into a Lower Mon Valley collaborative in which we had all the different social service entities down there to meet at least once a month, collaborate on what everyone was doing, and also with a focus on HIV, getting people tested for HIV and getting them into HIV care. And as you know, right now, UPMC McKeesport Family Medicine Program does have a track with HIV now. So some programs are pushing it in a way, like UPMC McKeesport, and other ones are probably still lagging.
So where would a physician find this information? I mean, this is a great conference we're having, but if they wanted to
I think one of the best
themselves.
places to, again, that's the easiest, accessible, and digestible is the CDC website. You just type CDC PrEP, and all the new guidelines regarding PrEP are there. You can also consult the United States Task Force Services, but again, I think they're lagging because, again, sometimes they're not including all the different socioeconomic groups. The guidelines that were being updated by the CDC, again, we're just starting to include more women who are receiving receptive vaginal intercourse. It was just starting to include transgender women in the studies, or I'm sorry, in the recommendations. I think there was a couple more here, but again, as far as I'm concerned, those guidelines that they're drafting this year, we've been doing that for 5 years already. So again, they're still lagging. And I think the problem is because they're not looking at the science. If you look at the science of how PrEP works, you will understand that it's going to work in all these different populations. Okay, there's no doubt. It comes down to who did the test, how the test was done, and then what the FDA decides to approve it. The other thing that clinicians need to remember is what? Once a medication has been approved by the FDA, what can you do? You can use it off label. So even though even though there hasn't been any recommendations, yes, you could actually still use Descovy in women, and it's not going to be an issue. Again, think about the science. This has been a problem even with the rollout of the medications for COVID or the vaccines for COVID. Come on, if you understand the science of how the vaccines work, you would have known years ago that you could have mixed and matched these vaccines. Okay, but again, they're going to wait until all the thousands of people have been tested and they've proven it over and over. And even though we have millions of people walking around here who've already had the vaccines are completely fine, they still lagging in their approval for the use. Anyway, back to PrEP.
Well, you keep going, and then I'm gonna just go on the other side of that, because I know I now work on the health insurance side, and you know that. And so I know, especially for people who are low income, it is very hard for them to get things that are not FDA approved, or at least has some compendium use of off-label use. So therefore, for that group, which is what probably a lot of the people are in, they are not able to get. How do you help those people? And then maybe you did talk about there's programs that give it free, and I guess maybe that's what maybe some clinicians need to know about, because I don't know that insurances are going to always cover for non-FDA approved.
Oh no, you can. I think you can. You can. So again, when it comes to people who are in the low socioeconomic groups, okay, again, we have a community outreach vans that go out and get people tested. Okay, I think the biggest thing that's missing today is we don't see the campaigning for medications like we did during the height of the HIV/AIDS pandemic.
Right.
We don't see people out there giving lectures in the churches, in the schools, in the colleges that used to happen. We don't see all those roundtable talks anymore. The other thing I can't stand these days is all the ads are so freaking glamorized. Like everyone has perfect skin and perfect teeth. They got their hair done and everything. That's not even reality, and that's not going to really appeal, because those people don't look like the people who were affected when you think about it.
That's true. That's true.
It doesn't. And again, one of the barriers, again, with respect to African Americans is that I was surprised when I saw that lecture on racism and bias earlier this year, in which that, Black folks, you know, even though we have Black doctors, Black folks still don't trust us quite a bit, you know? So there's a lot of barriers that need to be broken down. You know, there's still a lot of discussion that needs to be had around this subject, you know?
So I know I have another question. I have two I really want to talk about, but I'm going to ask this one. So you talked about PrEP and the use of PrEP, and then how many days afterwards they can go unprotected sex. Do they get any other protections from any of the other STDs once they're on PrEP, or are they still susceptible to other STDs? And then how do you guide your members then?
No, PrEP only protects against HIV. It does not protect against syphilis, gonorrhea, or non-gonococcal urethritis, or BV, or trichomonas, or any of those. No. So again, that's why you still must encourage patients to come in for routine visits. And again, for those patients, one thing I forgot to mention is, you know, I always ask about sexual activity. You know, how often, when is it going to happen? Because again, there are within the gay community, there are balls. There's the ball circuit, the ballroom circuits, and there are also something that we call circuit parties, okay? And we had a circuit party earlier this year in Pittsburgh. It was a river cruise, and it was actually really nice. I was on it. I just sat on a boat and just floated around, let all the young folks do what they do. But it was really nice because, again, we were present there, and we let the people who were enjoying themselves, let them know that they could come to the clinic, you know, on Monday for testing. And we actually had quite a few people. I think we had like 20 or so people come to get tested. And the other thing is that we had offer incentives for people to come in for testing before those events. So sometimes we'll offer discount vouchers that allow them for either entry or food or, you know, drinks or whatever, to come in and get tested before they go to these parties, and then also to come later and get tested after the parties. So I think we have to be aware of things that are going on, and where these people, peoples who are at high risk for HIV and AIDS are partying. And then again, we have to provide those services. Again, this is one of those things about meeting people where they are. Okay, so you have to go out and say, hey, we are here to test you, to keep you safe, and take it from there.
Well, you know, I was talking to you earlier. I belong to another board, Free AIDS of Pittsburgh, and we were talking about how do you take away the stigma of being HIV tested? How do you get more people to get tested? You know.
Well, again, I think it starts with having a candid conversation about sex. Okay, it has to start there, because again, that's the thing that's going to be putting you at risk, is engaging in sex. So you have to have the conversation about sex. It has to be casual, you have to be relaxed about it, and again, non-judgmental. And then you can say, okay, I want you to have sex the way you want to have sex, but I want you to be safe. Okay, so you can do what you want to do, but I want you to come in and get tested for HIV. You're at risk for HIV. I want you to go on PrEP. Okay, I want to test you for all these STIs, and then we're going to do some follow-up visits to keep you safe every 3 months. Or we're going to have you come at least, you know, if you're going out to these different events that involve the LGBTQI community, we want you to come in after these events to be tested. Okay, so I think there has to be, you have to give that patient a sense that you genuinely care about them. Okay, it can't just be this mechanical, you do this, we give you this. It has to be something that's a little bit more heartfelt, okay, and genuine. And I think if you do that, then you can engage these patients in care a little bit better.
So, I mean, we're talking about sex, and I mean, I know with like Garcilla for HPV, we just now do it to all. You know, you just start at a certain age. Do you see a time coming when perhaps that's either way we're testing for HIV, or we're just treating for HIV, or hopefully maybe have something on the market? Do you see what's coming in on the market that would just be able to treat someone one time and help them prevent this virus? Or I know that's a loaded question.
Well, there's a couple of different things. I think we're moving that direction. Okay, and so in terms of moving that direction, again, next year, there's a medication called cabotegravir, and it's an injectable medication which may be used for PrEP. The nice thing about cabotegravir is that the patients would only need an injection once every 2 months. Okay. This is the different type of medication compared to Descovy and Tivicay, in which this is a HIV integrase strand transfer inhibitor. So again, this prevents proviral DNA from entering in the host cell altogether. Okay. As to preventing the replication. Now, the claim to fame of cabotegravir is that it's 69% more effective than daily pills. I don't know exactly what that means. It could be that the data that they're using to justify this includes people who are non-compliant with taking HIV, because again, the efficacy of the pills is 99%. Okay, now the advantage is that the half-life of cabotegravir is 6 to 11 weeks. And as such, again, the patient only needs an injection every 2 months. Okay, now let me give you a little bit more information about that question, because like you said, it's a little bit loaded. And like I said, we're moving that direction. Originally, I can't remember the name of the medication right offhand, but again, there was a injecto or IV medication for HIV that was used that bound to something called a CCR4 receptor. And again, you know, the thing about it is, yeah, it would partially block HIV, but I don't think the efficacy was all that great. And again, if you go back and look at the original information about the keys to HIV prevention, it says something about the CCR5 receptor. Now, if you block the CCR5 receptor, guess what? HIV ain't getting into that cell. But the problem is what? CCR5 receptors are located on different types of cells. So you may be blocking the function of other cells that you don't have to worry about HIV in that sense. Okay, so I think they need to use this technology that they're using for COVID, the mRNAs, because again, that can target sections of DNA and go in and then I don't know, maybe again, let me think about this just 1 second, because you got me going here a little bit. But I think, again, because again, there's lots of variations of HIV out here, but I think they ought to be able to use the technology, the mRNA technology that they're currently using for COVID for HIV. The interesting thing is that this technology has been around for over 10 years. They've just come to push it to the forefront with the COVID pandemic.
Right. Mm-hmm.
But I'm hoping again soon, probably within, I don't know, who knows, within the next 5-10 years, that they'll come out with something with a vaccine for HIV and then something that will eradicate HIV altogether.
Yeah, I mean, that would be the ultimate goal. So, you know, you were talking about PrEP and you were giving dates of its effectiveness. So if people miss doses, you know, they are still protected, it sounds like, for periods of time. How do you get them back on their regular schedule? How do you, what is your recommendation if they have missed dose? And then what do you do with people who just don't want to take it at all?
Again, we just have people restart the medication. Okay, the medications for HIV, which I'm going to call 4th generation HIV medications, are very forgiving. Okay, so again, the initial HIV medications, and then we're going to get back to PrEP. Initially, again, if you recall back in the the 90s, those medications had to be taken at this exact time every day. Okay, that is not the case these days. The patient can take the medication at 7 o'clock in the morning today. They can take it at 3 o'clock tomorrow. They can take it at 9 o'clock the next day. They can take it at 10 o'clock the next day, and they're still going to be protected. Okay, if they miss a dose, just restart it. Okay, if it turns, now I don't have a real set time period in terms of like in which I would say take 2 to get that loading dose back up again. Okay, but we would again take them to the usual testing to make sure that they are HIV negative and discontinue from that point on. All right, and then let me give you a little bit of other information. Okay, my experience also has been, I've seen patients taking these 4th generation HIV medications and have been off of them for even as long as 5 months. Okay, they come back, we put them back on the medications, the viral loads drop back down to undetectable, sometimes with even 3 weeks. Okay, and when we run the resistance patterns, there is no resistance developed against those medications. So the medications are very forgiving, they're very effective these days. And then for patients who don't want to take PrEP, again, you have to, again, engage in that conversation about sex, sexual preferences. You also have to, again, educate that patient with regards to their risk factors and why it's important for them to consider going on PrEP. You have to let them know that the door is always open for them to come in at any time to start PrEP and for HIV testing and STI testing and everything else. So again, it's not like, well, having an attitude like, well, if you're not interested, I don't want to be bothered with you, does not work. You have to completely, again, show that you're caring and keep that patient engaged in all aspects of their care. Again, you can, my patients, again, if they're gonna get a little funky with me, I'll make sure they come back in 3 months. I'll make sure they're scheduled for their appointment before they leave. Okay, so I think you also have to be proactive. So there's nothing wrong with sending those patients emails or text messages or sending them messages through the patient portals for reminders to come in. One of the things I tell people all the time, you must give people the opportunity to say no. Okay, yeah. So I think we must be proactive. And, we can't control people's decisions. We can try to influence them as much as we want. But again, at the end of the day, we still need to be proactive and give them that opportunity to say no. Okay.
So you're going to teach me something because, I deal with your office. Again, in my job, I deal with your office. We could be candid. As we said, this is the fireside chat. I had a conversation with someone in your office, and this is someone who is HIV, but she was talking about doing the injectable. And I'll be honest, I don't even remember the name of the program, but you know what I'm talking about. And yes. I think they can do it once a month as opposed to having to take something every day. And she said to me, well, when they do it once a month, they don't have to think about they have the disease. That threw me a little bit, because I said, well, it's the same with the diabetic or someone who has diabetes or hypertension. Everybody has to think about their disease every day, but maybe I didn't understand the bias to this disease. Or, what is the stigma for them who have it? Maybe you can talk on that.
No, I think again, what I'm thinking that patient may have been expressing is the fact they don't have to take a medication, which means I don't have to take a medication, so I don't have to think about it. I just come and take an injection. So again, at least for 29 days per month, I don't have to worry about it for sure. Okay, it just gives them a sense of relief. Okay, so the medication we're talking about is Cabenuva, which is a medication that eventually evolves into injectable form for the maintenance of HIV. Okay, it starts off 30 days in which you take ripivirine and cabotegravir tablets. Okay, for 30 days is a loading dose. And then there's an injectable loading dose that is a higher dose than a maintenance dose. And then there's a maintenance dose that the patients come in every month for an injection. There are 2 injections given in individual hips. And then those, you always make sure you know which side you're giving the injection in case the patient has a reaction.
All right. But, I guess it all just leads into, we're talking about the bias of the community, bias of physicians, how culturally do you work this in? I think we as a community have come a long way with HIV and AIDS. As I said, I remember back in the 80s, if you thought someone had AIDS, because we actually saw AIDS back then, I don't think we see it as much as we do now. And that's a blessing. It does mean that we're progressing. But you didn't want to touch them, you didn't want to be near them, and I think we have moved, but how do we continue to move? How do we continue to progress with not only the HIV, but just with the LGBTQTA community altogether? I told you I messed up those initials somewhere. But how do we just progress as a community in accepting this community as a whole?
I think the biggest problem is that we do not have unity. Okay, we have this behavior in which you compartmentalize, like I said, all of a sudden I am Black and I'm gay and I'm light-skinned and I'm educated, we compartmentalize ourselves and then we wind up in these like little subcultures. We need unity. That is the bottom line. We must have unity. There's got to be love. It has to be unconditional. And then with that being said, everyone is back together again. And it's a cultural shift. I think what happened is we had a culture, when you think about, in terms of like the civil rights movement. When you look back at the civil rights movement, you look at the pictures and you get the history of the people who were involved in that. Everybody was involved in the civil rights movement. Everybody was involved in the civil rights movement. I mean, again, we have this Bayard Rustin event that's coming up in a couple of weeks here in Pittsburgh that's being put on by Derek Tynes. Well, you look at we had gay folks, queer folks, white folks, Jews, everybody's involved in the civil rights movement, okay? But what do we have today? We have communities that are fractionated. And believe it or not, I have not seen so much fractionated communities since I've lived here in Pittsburgh. And I grew up in Cleveland. I grew up 3 blocks from the epicenter of the Huff riots. My parents were community activists. I used to sit up on the stairs and listen to their meetings. We were supposed to go up because the adults were talking. I used to sit up on top of the stairs and listen to their conversations. And then our activism has to be joint. Again, we have this group marching and then this group marching and then that group marching. We all need to march together for all of our causes. Okay, the unity must come back. A couple of weeks ago, they had the whole Dave Chappelle thing that was going on with the trans community. I was kind of ticked off by that because, again, it wasn't that they were protesting. The problem is that if you are going to protest trans women abuse, okay, then you need to have protests for abuse against women.
Right.
And we know for a fact, okay, so what was it? 44 trans women. Again, I'm not minimizing the trans community. Don't get me there. Again, this is about unity. This is what I'm talking about here. Then the trans community and the other communities and the other community and the other community need to back up protesting against these 4 Black women who are killed every day in the United States, okay? They need together. So again, we need unity. So there should be no killing of any woman. So there was a big women's march, I think, that was held earlier this year, but everyone needs to be together, okay? There should be men at that women's march also, okay? There must be unity. And once we have unity, then we're gonna have a cultural shift. Once we have a cultural shift, we're gonna all be in the same pot. We can have these discussions, and then we can move the entire community out of this environment, what they call this social determinants of health. We can start eradicating. That's how we eradicate it. We have to support each other. We do, we really do. And so,
yeah. Go ahead. No,
yeah, so, and then again, the education has to take part. We need, again, continue the education of the churches and in the schools and in the medical schools, the re-education of doctors every year, because I'm getting sick of these articles about the next medication that comes out that is useless. Okay, it's just another medication, another medication, another medication. And again, the things that they talk about the medications, we already know. I mean, I was surprised they came out with some study about like a ACE inhibitor and stage 3 chronic disease. Again, if you were giving someone an ACE, you should know to monitor kidney function. I don't need a study to tell me that. It's just like stupid crap. So we need to get back to unity. We need to get back to those things that are going to solidify the community. We need to get back to those things that makes the entire community healthy.
I think that's a good point for us to end. I think that's why we as physicians, we want to take care of the total community, not just individuals, but everybody. And I think Dr. Isaac had mentioned that I am an ordained minister, but I still see that unity and love and unconditional love is what is needed throughout. I think that's what Jesus preached, is unconditional love. And I think that's what we as communities need to learn to preach, is unconditional love. And then I think at that point, no matter what illnesses, because we all have some illness, they can all be addressed, because there will be no stigmatism, and I will accept you for you. I want to thank you for this chat tonight. I thank you for all the information. Why don't you tell us again what resources are available for people, physicians, if they want to get more information, and or if there's any people on where they can also get. We should do that one more time. Just give them.
Yeah, so again, regarding information regarding PrEP and HIV, again, I think one of the best resources is the CDC websites. Again, in terms of guidelines for prescribing and initiating PrEP, you can look at the United States Preventative Task Force Services. Right here in Pittsburgh, again, we have Central Outreach Wellness Center. We have the Allegheny County Medical Department. We have Allies for Health. We have the Positive Health Clinic. And we have Planned Parenthood, who are also resources. Okay, and then lastly, again, there's a really great website. It's just called The Body, all pushed together as one word with a capital T and a capital B. And that's a very good resource that where you can actually enter in your questions regarding care of HIV patients and PrEP, and those doctors will get back to you with really, just really good answers.
All right. We thank you again. This was lovely. I think the information was well needed, and we'll have to have you back.
Thank you so much.
We thank all of you who have come on with us. Again, if you want CME, remember to email administration@gatewaymedicalsociety.org to get your CME along with your name. And we hope you will join us. And if you have missed any of this or have someone who wants to view it, it will be on our website at gatewaymedicalsociety.org. Have a good night.